I'm talking today with Janet Rankin, who's a professor of nursing at the University of Calgary School of Nursing and who's written with
Dr. Marie Campbell.
A book called Managing to Nurse. And Janet, tell me and tell the folks who are listening in why you wrote this book and a bit about what you found in this discussion of the impact of managerialism on nursing practice and patient care.
Right. Well, what I did was I did research because I was very concerned about what I saw starting to go wrong in nurses' practice. I had been practicing since the 1970s, and as I was taking students back into practice, I was starting to see that nursing work that I had identified as very important work was not being done, and I started to recognize that patients were suffering, I felt, as a result of this important nursing work that was going undone. And I recognized that it wasn't nurses who were making necessarily independent choices to overlook the kind of care that I thought was important, but that there were strategies such as critical pathways and length of stay parameters and various other efficiency protocols that were being introduced into nurses' work that was not allowing nurses the time to do what I thought were really important components of care.
And nurses were complaining to you about things like speed up and
especially senior nurses who I would talk to were very concerned about what they were seeing in regards to what new nurses were noticing in regards to patient care. And so the details of care that older nurses felt were very important, such as the beginning of skin breakdown, such as the early signs of a urinary tract infection, such as a patient who was going into early stages of confusion, were not being picked up because nurses simply didn't have the time to attend to the patients and to be able to recognize these early signs of serious consequences of health issues.
And to what do you attribute the fact that nursing practice was being impacted and nurses were somehow struggling with all these new and difficult things that were impacting their practice and patient care?
Well, I think what happened is that healthcare administrators recognized that nursing labor was one of the big costs of providing health care, and so they started to scrutinize nursing labor in regards to how nurses could be deployed into the nursing units, and we started to come up with workload indexing strategies, which were calculations as to how many units of time each particular patient might require to look after. And then after they had scrutinized nursing labor in regards to the deployment of nursing labor, the actual patient needs started to become scrutinized. And as you know now, length of stay started to be rigidly predicted from the outset, and patients were sort of allocated standardized length of times to which they were going to be able to be hospitalized. And unless they actually came up with particular variables that were preordained variables, those patients would have to be discharged on their day of discharge, regardless of what their home circumstances or the demands on them or their personal circumstances, age, socioeconomic status, any of these sorts of things that we know impact on a person's ability to maintain their health once they're discharged from the hospital.
And I think what's really unusual about your book is that you talk about these strategies and these standardizations and these attempts to create patients as predictable units of production were not simply imposed on nursing, but imposed by nursing and actually taken up by and embraced by nurses.
Yes, and I don't want to sort of get into blame here because I think that nurses are doing the finest job they possibly can, and I think managers are actually also have the intention of providing really good patient care. But I think what's interesting is that these industrialized approaches to healthcare are introduced to nurses, and most likely their managers too, as though they're going to solve the problems for nursing. And I think that that was probably the big finding of my study, is that nurses do embrace the solutions that they think are going to relieve the pressures on their work. When nurse workload index was first introduced, nurses were told that this would be a way that they could provide evidence that they needed more nurses when they called the nursing office. And in fact, what happened was when they started to standardize those workload indexes, nurses were then told that their numbers didn't didn't require more nursing
Right.
staff. And so all of those sorts of strategies. And similar to the standardized length of stay, when nurses are discharging patients prior to in order to open up beds, then they're introducing sicker patients, and the whole sort of notion of sicker and quicker just completely increases the pace of nurses' work. So nurses look at these solutions, think that they're going to work for them. They start to use them, and then suddenly not so suddenly, but what they come to realize is that they're just working, the pace of their work has just been completely increased.
So they become prisoners of the strategy as opposed to the strategy becoming an aid that will help them. They are actually captured by the strategy and they can change it. I think benchmarking is another one of these things where I've never heard of a benchmark that is slower. Benchmarking always means speeding up in work intensification.
Yeah, exactly. And it sets up competitive relations where one hospital will have a different benchmark and have demonstrated that they can actually reduce the length of patient stay for certain procedures and protocols, and then all the hospitals are held up to that same benchmark standard.
Right. So what is your advice to nurses about how to deal with these or to resist these kinds of managerial strategies?
Well, I actually think that nurses need to work as a collective. I think that, first of all, we need to grasp an analysis of our work. I think we need to understand how the promises of these technologies, the increasingly computerized approaches to medication administration, electronic medical charting, are actually providing data and information that does not provide a realistic perspective of what nurses know is going on the ground. And I think nurses have to really be clear about what it is that they're seeing in patient care, what we know from being on the ground of nursing care, and try and find a way to talk back to the sorts of evidence that are being promoted by health services research that tells a different story, that in fact there's nothing wrong in healthcare and that patient care is improved and that outcomes are better. Because I do think that nurses on the ground know that very differently.
And I think one of the things that people listening can do is read your book, and that'll help them understand and formulate a critique that's really necessary. And the book again is called?
It's called Managing to Nurse Inside Canada's Healthcare Reform, although it certainly has wider application, I think, to the United States. In part because what's going on in Canada, we actually looked to the United States and the sorts of strategies that the HMOs were putting in place in order to improve profits, and the Canadians started to see that they were a way to reduce costs.
Right,
costs.
And I think particularly with the entrance of Six Sigma into hospitals and Toyota Lean Management, this is a really important book. So thank you for
Thank you
speaking
very
with
much.
us.
Thank you.